looked at how to interpret a basic EKG strip, let's start looking at some dysrhythmias. In this video, we're going to be looking at dysrhythmias considered sinus dysrhythmias. So remember, we are talking about our gold standard as a comparison, our sinus rhythm. When looking at the 5 characteristics of an EKG strip, a sinus rhythm is a regular rhythm. So we said that measuring R to R intervals are going to be equal. Our heart rate is regular. The rate of our heart rate is going to be at a rate of 60 to 100 beats per minute. On this strip, we can count the number of R waves, 1, 2, 3, 4, 5, 6, and know that the heart rate for this patient, we have 6 R waves, we multiply by 10, 6-second strips times 10 gives us 60 beats per minute. That's within our range for sinus rhythm. Is there one P wave for every QRS, and is it upright and rounded? So before each QRS complex, we can see one upright rounded P wave. What is the PR interval? If we measure the PR interval from the beginning of the P to the beginning of the R wave, where that Q starts to go down, that PR interval is going to be less than 0.20 seconds. Is the QRS narrow, meaning less than 0.12 seconds? So we said 0.12 seconds is 3 boxes. Is it smaller than 3 boxes? If we measure from the beginning of the Q, where the Q starts to go down, to where the S wave comes up to the J point, it should be less than 0.12 seconds. We can go through those 5 steps and know that this is a sinus rhythm. Here are 2 other sinus rhythms. Again, they look a little bit different, but if we walk through our 5 steps, we'll be able to determine that these are also sinus rhythms. Our R to R measurements are going to be equal, so that's going to be a regular heartbeat. If we count the number of R waves in the top strip, we have 1, 2, 3, 4, 5, 6, 7, 8, 9, a heart rate of 90, which is within our parameter of 60 to 100. We have 1 upright rounded P wave for every QRS complex. If we measure our PR interval, it's going to be less than 0.20 seconds. And if we measure our QRS, we are going to have that narrow at less than 0.12 seconds. So the heart rate in the bottom strip would be 1, 2, 3, 4, 5, 6, 60. So the top strip has a heart rate of 90. The bottom has a heart rate of 60. They are both considered sinus rhythms. So what happens if we have a sinus rhythm that has a rate that's slower or faster than our 60 to 100 parameter? This is where we're considered to have a sinus dysrhythmia. So one of those 5 things in our sinus rhythm, the heart rate is going to be different. We know that bradycardia is a heart rate less than 60, so we can look at that. Sinus bradycardia is going to have a regular rhythm. The heart rate is going to be less than 60. Can you tell me what the heart rate is in this strip? We'll get back to it. There's a normal sinus P wave. Again, 1 upright rounded P wave for every QRS, no more, no less. The PR interval is going to be less than 0.20 seconds. And the QRS is narrow, less than 0.12 seconds. Do you have that heart rate? Counting those R waves, the heart rate in this strip would be 40. We're going to assume that every strip we look at is a 6-second strip. So we said sinus bradycardia is a rate less than 60. Let's think about our patient that has bradycardia. So we've looked at the monitor, we see that they're in sinus brady. We have to assess our patient. Is our patient stable or unstable? By unstable, I mean, are they symptomatic? What kind of symptoms would we have if we had bradycardia? So if you're an athlete, if you're active, you may have a resting heart rate of 58 or 56. For you, that might be perfectly okay. You're young, you're healthy, you have a good, strong heart. So you may be asymptomatic at a heart rate that is less than 60, pretty close to 60. But if our heart rate drops lower, 50, 45, 40, we're going to start becoming symptomatic. What are some things that cause our heart rate to get low? What can cause us to have bradycardia? A Valsalva maneuver is one thing. So if a patient is having a bowel movement and bears down, that can put pressure on the vagal nerve, and that vagal nerve can make our heart rate drop. For you and I, that's probably okay because we have a strong, healthy heart that can bounce back. But for patients who are cardiac patients or who are taking medications to prevent their heart rate from elevating, this could be problematic. This is one of the reasons that we have our patients who are cardiac patients on stool softeners, so they aren't straining and bearing down that Valsalva maneuver that could cause them to have bradycardia, maybe become lightheaded and pass out. Low metabolic needs. Again, if you're young and healthy, your heart may function very well at a little below 60. So if we don't have a lot of needs for that, if our body is not needing extra oxygen or extra ability to fight infection, or we're not dehydrated and so it has to work hard to pump blood around the body, then it may function very well with good cardiac output at a little less than 60. Other things that could cause sinus bradycardia are heart injury or brain injury. So a heart attack, increased cranial pressure. Also think about medications that are given to patients to interrupt a dysrhythmia. Some of those anti-dysrhythmics are digoxin and amiodarone. Beta blockers, remember, they are blocking the sympathetic response. It can slow down the heart rate. Also, calcium channel blockers are blocking the muscular contractions, some of those contractions of the heart, so they could slow down the ability of the heart to continue those beats that the patient may be having. And then any sedatives, so patients that have been on anesthesia, patients that are getting pain medication, patients that are getting sleeping medicine, any of those kind of things, we have to watch their heart rate because it can drop too low to where we're not supporting cardiac output. Remember, if the heart rate is too low, we may not be able to meet those metabolic needs that the body has. Patients can get lightheaded, they can fall, they can become injured. So a high fall risk if a patient has sinus bradycardia. Unstable, what would those symptoms be? Think about decreased cardiac output, chest pain, shortness of breath, change in level of consciousness, change in skin color, temperature, hypotension, dyspnea, again, skin color, color of the mucous membranes, all equaling decreased cardiac output. So what do we do for patients that are bradycardic? Again, you may be bradycardic if you are in very good shape and your heart doesn't have to beat a whole lot of times because your contraction of your heart is so strong that it's supplying the needs that the body has. But if our patient is unstable, if they're symptomatic, if we're not supporting cardiac output, we have to identify what's causing it. What is the cause? Is it a medication? Is it a head injury? Is it that part of the heart may be damaged? We have to treat the underlying cause. Drugs that are suspected of causing bradycardia are going to be discontinued. We can also administer a medication called atropine. Given IV, atropine actually stimulates the sympathetic response. So it stimulates the beta receptors, increasing the heart rate. increasing vascular volume. So we may need IV fluid to be able to help our body to get those things like oxygenated blood supplied around with the number of beats that we're working with. And then we may need to give them oxygen. Again, if we're talking decreased cardiac output, one of the symptoms could be shortness of breath. Give that patient some oxygen. We may need to prepare for a way to supplement that heartbeat. Transcutaneous pacing. Transcutaneous means through the skin. They can put external pacers or external adhesives to the outside of the patient's chest and stimulate the heart to increase the number of beats. So this may be done temporarily until a permanent pacemaker can be placed, or it can be done while we're trying to treat the cause of bradycardia. You can do transcutaneous pacing with a defibrillator. There's a setting on there. So we may be assisting while they are pacing that patient. Preparing for a permanent pacemaker, we said. So again, we can attach those transcutaneous pacers that are going to help stimulate those heartbeats. We can set it at 70 and it will stimulate the heart if it is beating less than 70 beats per minute to make up those beats. So let's look at the other extreme. Let's look at sinus tachycardia. We know that tachycardia means a heart rate greater than 100. So sinus tachycardia means that our sinus rhythm is still existing. We're still beating from the SA node. We're still having electrical conductivity that goes the SA node to the AV node all the way to the Purkinje fibers. It's just that we're having more than 100 stimulations from that SA node every minute. So our rate's going to be increased. Everything else on that EKG strip is going to be just like our gold standard of sinus rhythm. So if we look at the strip, we can see that it's a regular rate. And I would know this by measuring the distance between my R to R waves throughout the entire strip. They're going to measure the same distance apart. Our heart rate that we get from counting the R waves is going to be 100 to 150. And I'm going to let you count the R waves in that top strip there, and then we'll get back to it in just a minute. Is there a normal sinus P wave? Can I identify one P wave, one upright rounded P wave for every QRS? And yes, I have one upright rounded P wave for every QRS. If we measure the PR interval, the beginning of the P to the beginning of the Q, it is going to give us less than 0.20 seconds. And then that QRS is going to be more narrow, and it's going to be beginning of the Q to where the S joins back to that isometric line at the J point, and it's going to be less than 0.12 seconds. So we look at the PR interval being 5 boxes or less, and the QRS being less than 3 boxes. And again, those teeny tiny boxes within the grid are going to help us measure. And so we'll make sure we get lots of practice doing that. So back to that strip, what did you get as the heart rate? Let's count. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Multiplied by 10, this heart rate is 120. So it meets the sinus tachycardia definition. Is our patient symptomatic? Remember, our heart rate of 60 to 100 is providing an adequate amount of beating and contracting to keep our cardiac output at a rate that it should be to get oxygen around our body. So if our patient with sinus tachycardia is symptomatic, we're going to see an impairment in cardiac output. Why is this? Because the beats have to allow the QRS, the ventricles, to fill up and to contract in order to get that oxygenated blood from the left ventricle through the rest of the body. If our heart is beating so fast that the ventricles are contracting too many times before they get to fill up completely, then we're not going to have good cardiac output. So with sinus tachycardia, we may actually have some of the same symptoms as bradycardia: shortness of breath, chest pain, diaphoresis, pale skin, change in level of consciousness. How do we treat it? We treat the cause. What could be causing sinus tachycardia? And we're going to look at that. We also may give beta blockers, metoprolol, atenolol. Those are given most frequently when we're treating sinus tachycardia. What's the heart rate of this patient? Can you count those R waves? Let's count them. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. This patient's heart rate is 140. It's too fast. Our patient's going to be symptomatic. If we called the doctor and told him, he would probably order some IV metoprolol. We would administer that and monitor this patient's heart rate so that we can keep the sinus rhythm and decrease the heart rate into a sinus rhythm versus a sinus tachycardia. So what are some things that cause tachycardia? What are some things that cause our heart rate to speed up? So before we look at the list, if we think about things like pain, anxiety, exercise, caffeine, all of those kinds of things, but there's some additional ones. Too much or too little body fluid. So think about our vascular system, hypovolemia, low body fluid. Our heart has to beat extra fast to get that small amount of fluid we have all the way around our body and back to be reoxygenated. We're also going to see sinus tachycardia with hypervolemia. Hypervolemia is putting extra pressure on the heart by having so much fluid entering our preload, and then also having so much fluid going through that aorta on the way out after load that it has to beat fast and extra hard to make sure it gets all of that blood oxygenated. Hypovolemia we think about with anemia, but also thinking about a normal volume of fluid, but low red blood cells, low hemoglobin. Again, if I only have so much hemoglobin to be oxygenated, I'm going to have to pump faster to get that oxygen into into the hemoglobin to move around the body more quickly. Hypoxia, low oxygenation, the body's response is to speed up that heart rate to try to move it around the body more quickly. Heart failure, again, if part of the heart isn't working properly, heart failure, we usually have a problem with fluid, and we usually have a problem with the contractility. So the heart failure, again, the heart is thinking, how can I make up and get oxygenated blood around to the body? How can I increase cardiac output? The first way it's going to turn to is increasing the rate. Shock, except neurogenic shock. Remember, shock, we're thinking about fluid volume, we're thinking about infection. Those things put stress on the body, increased metabolic demand. Hyperthyroid increases the metabolic rate. Fever, our body is going to increase that heart rate to try to get rid of some of that heat that the body has generated. Pain and anxiety, again, our pain response. Any stimulants, including things like caffeine, but also other drugs that are considered stimulants like decongestants. And then medications like theophylline and epinephrine that we think of giving during an anaphylactic reaction that are bronchodilators also have a side effect of sinus tachycardia. Patients may also have orthostatic hypotension. Remember, hypotension comes from low fluid in the body. So if we don't have enough fluid, when that patient changes position, the heart isn't able to compensate and move that fluid with increasing the heart. So if patients have orthostatic hypotension, what we're going to see is as that patient changes from lying to sitting to standing, the heart rate will increase and the blood pressure will decrease. So that is our discussion of sinus rhythm and sinus dysrhythmias, of sinus bradycardia and sinus tachycardia.